But Wendy, tell me kind of where you found you were having some issues.
Okay.
Kind of walk me through the story.
Well, I went to my gastroenterologist. I have Crohn's disease, so he was doing a CT scan. I was having some issues, and he called to give me the results of the CT scan. And then he said, but I see some other problems in your lungs, and I need you to see a pulmonologist like within the next week or two.
Well, you were like, wow.
Yeah, that's fun.
Surprise.
Sorry.
It's okay.
So I called, of course, and I said, I've got a referral, and they said, we're sending your referral right away to Lynchburg Pulmonology. So I called because, you have to advocate. One thing I have learned, you have to advocate. And they said, we got your referral, and our first appointment will be February. And this was in June, early part of July.
February of next
2026, right. So Gastroenterology Associates is not owned by Centra, so they were able to refer me to Charlottesville, to Duke, and I got in with them within 2 weeks.
Okay.
Yeah.
Now, there was, this was not kind of you can wait until February of next year because your doctor was concerned about some things.
Yes.
This was like an ASAP.
Yes.
Talk to me about that.
So it was just, what they found was a lot of nodules in my lungs and a lot of scar tissue. And I had a really bad case of COVID, and then I had a really bad case of pneumonia where I was in the hospital like 9 days. And he just wanted that to get looked at, and come to find out I do have a disease called pulmonary fibrosis. So like my doctor said, I'm glad you came in, and they were able to, at least start getting some things done to where, it won't get better, but at least they can start treating things right away.
So it's good that you're able to start that treatment
Absolutely.
sooner rather than later.
Absolutely,
Yeah.
yes.
Were you surprised by how long it was going to take for you to get in?
I was shocked. I mean, I knew that there was a problem with people getting in, even to see your own primary care doctor. Gone are the days, it seems like, of I'm sick today, and they say, well, we can see you, in 2 days, or you can go to urgent care, which now, urgent care is now you have to have an appointment, or you can go to the ER. So then that kind of falls into, that's why our ERs are so crowded, because they don't have anywhere else to go. And through this, I found out with Medicaid, I have great insurance through my employer, but the people who don't have Medicaid, they can't always just find a doctor. They just won't take them. And I often think about our elderly population. They may not be able to drive 2 hours away, or have to find somebody to take them, or a low-income population who maybe does not really have a car, or maybe the money to drive that far away. And with it being just the one hospital system here, if your group is owned by Centra, they cannot refer you out of a Centra network.
Oh.
So you
got the referral. This was in June?
Yeah, last week of June, first week of July.
How quickly were they able to get you in Charlottesville?
2 weeks.
Okay. Mm-hmm. Wow.
Yeah, and then Duke, I called Duke as well. They sent it there as well. And they called and were like, hey, we can get you in 2 weeks too. It was like a couple days after my appointment in Charlottesville, but I was very pleased in Charlottesville, so I just stayed there and canceled that appointment, of course.
Okay. So you had to, drive an hour and 20 minutes, but you didn't have to wait.
Right, exactly, right. And the blessing is I'm able to do that. Not everybody is.
Right. And so tell me how things are now.
Yeah, I'm doing well. It's a process. It's a lot of lifestyle changes. You kind of have to push through. I was walking like 2 or 3 miles a day a year ago, and I'm finding I can't do that as easily. So it's just lifestyle changes. My life is definitely changing. And that's okay, because I'm still blessed. I have so many blessings, who can complain, Yeah. So.
Do you have the scan of your lungs, the CT scan that they saw? I mean, do you have a picture of that?
I do not,
okay.
No, I do not.
I wonder if your primary would give you...
I don't know, I can check and see.
Would you mind checking for
Okay,
me?
no.
Okay. Couple more questions.
Okay.
Have you, when you started to tell your story, friends and family or whatever, they're like, oh gosh, that's happened to me too. You start to tell a story and everyone's like, yeah, I've had the same problem.
Yeah, it's that, and people who cannot get into their primary care doctors. So they wound up, just going to a walk-in, and it's like, oh, it's not a walk-in, and all our appointments are taken at 8 a.m. And so it's very frustrating for them.
Yeah, was that a frustrating situation for you in the beginning when you?
Frustrating and shocking. Yeah, really shocking. Yeah.
That's so. You said that you just got notice about your appointment in February.
Yeah. They were like, "Here's paperwork for you to fill out for you," and I was like, "Oh, it's February. Okay.
Don't need that one anymore."
Right. I'll have to call them.
Yeah.
Because I thought I canceled that, but here we are.
Okay. Well, I think that's all the questions that I have. I guess the big question that we're trying to answer here is, where are all the doctors? And that's not an easy question to answer.
You're right. What I will say from a Lynchburg perspective is everyone is asking the same question. There is no community in America that has more than they could use. It is also a variance by specialty or subspecialty. So even if you have an abundance of surgeons, you probably don't have enough primary care physicians. We've seen a reduction in the availability of physicians related to just the aging of the physician population, the changes in regulations, the amount of paperwork that's expected, the computers that have been integrated into daily care. And so we're having to be creative in the way that we position the physicians so that we can make them as efficient as possible.
Okay, so let's talk about how you're getting creative with that.
Okay, probably the most exciting thing that we're doing is that we have started integrating AI into the patient visits. So the physicians no longer bring their computer in and look at the computer instead of at you. They bring their phone in. The AI is able to listen to the conversation and generate a note that the physician reviews, and the note doesn't include any extra conversation. It is focused and really saves them time on documentation.
Okay. As far as the care structure is concerned, because is it you're having a hard time recruiting physicians? Is it a hard time? Is it that there's not enough out there? Is it a two-pronged problem, three-pronged problem?
It is a two-pronged problem. There aren't enough out there, particularly in certain specialties. But I think the other is finding physicians that want to work in a rural environment. And I would tell you, I've never worked anywhere, and I've been in several different systems that we haven't felt like it was hard to recruit. So I don't think Lynchburg is harder to recruit to or is unusual in the pressures that we're facing. It's really just that it has to be a fit for that particular physician to get them to come.
Yeah, I think the people that live in this area would say, we're not rural. This isn't a rural healthcare system, but it is.
It is. We're far away from the bigger cities. And I think people underestimate us. That's the other thing that I would share is that we have some incredibly complex services that we offer. Heart and vascular is a great example. We've got pediatric cardiology, we do heart caths, we do a variety of procedures that you would assume that you would have to go to an urban city to have access to, and we've got it right here in Lynchburg.
Okay, so we've also seen, if you look at the census, the population in this region growing as well.
Yes.
So it's meeting that demand as well.
It is. We do an assessment every 3 years as a system. Most systems do. And what we look at is population growth, and we look at the demand by subspecialty of the population that we have. And that actually informs our recruitment plan. That's how we know we need 44 more primary care physicians in the region. And some of it is response to retirements, but a lot of it is response to just the number of people in our population who need care.
So you said primary care is tough to recruit. Tell me what other areas.
I hope you have enough time.
No, but seriously.
So we are seeing it in endocrinology is hard to recruit, urology hard to recruit, generalist position. So a general surgeon rather than a surgeon who specializes in a certain type of surgery. General cardiologists are hard to find because, again, it's a very broad set of patients rather than a focused set of patients. Primary care, so there are many specialties that are difficult.
I asked on Facebook, from some of my, let me start that. I asked on Facebook, where are you seeing some issues trying to find care? And endocrinology was a big one for a lot of people. Why is that such a in demand without the supply?
Believe it or not, the reason is that endocrinologists have to do a fellowship after they do their primary care training, but they're actually paid less than primary care physicians are if you look at the national data. And so they are either choosing to be primary care only or they are choosing to train in a different specialty.
Interesting. So part of the approach here is not just hiring a physician, but also hiring a team, hiring a nurse practitioner or a physician's assistant. And I think some people are having a hard time wrapping their heads around that is the continuum of care at this point, and that's where we are, and probably other healthcare systems as well. They want to see their doctor every single time. They want that way that they've grown up in a medical environment. Is that just not going to be the way it is anymore?
It is not going to be that way. Physicians will be focused on two things. One is being the team leader for what we call our care team. And so it's usually a physician partnered with one or two nurse practitioners or PAs, and he is the leader of that team. He or she is the leader of that team, and kind of directing the care that the patient gets overall. But the physician is also focused on the most complex of the patients. So if we have someone with multiple chronic diseases that are currently active, the physician may see them until they are managed relatively well and then hand them off to the nurse practitioner or the PA so that then the physician has room to accept another new patient to care for.
Now, when you're looking at the people who are graduating with a degree, are more people going for the nurse practitioner or physician's assistant route for whatever reason than going to medical school to be a physician?
I don't know the statistics off the top of my head, but what I can tell you is that nurse practitioners and PAs have expanded exponentially in probably the last 10 to 15 years. We're seeing that in other specialties as well. We're seeing, we call them advanced practice providers. So if we don't have enough physicians, that is being filled in by psychiatrists, to support psychiatrists, by psychologists, mental health professionals, social workers. We see that in surgery, where the surgeons typically have partners who are a PA or a nurse practitioner who help them in surgery and who also see the patients in clinic post-procedure. And it requires less training, and you still get that patient care exposure, and maybe your financial investment is less. So we do see that as an attractive alternative for a lot of people who are interested in being in healthcare.
Do you think you're still getting the same level of care if you're not seeing a physician every time?
I do. The nurse practitioners and PAs are typically driven or led through protocols. So if I've already had a procedure and someone needs to check my surgical wound, or they need to follow up on my A1C, so my level of glucose in my blood, then they have references that say, if the numbers are this, or if the incision looks swollen, this is what you do. So I do feel confident. I would say that I was a late acceptor of the advanced practice professionals. You
admit to that.
I do, and I've been working with physicians for 30 years. So, I just wasn't sure, but I can tell you that I get more time to spend with the nurse practitioner or the PA than I normally would with a physician. And at this point, I'm probably more worried well than I am actually not well. And so it's a great fit for me if I want access in a timely manner, and I want that time to be educated or to talk through options.
Okay, we're sitting in the new facility on Langren Road, the new medical center that Centra is building. How is this going to help with care in our area?
So it is going to bring several, I think, benefits to the community. One is moving a large proportion of our specialists into one location so that they can communicate with each other. Right now, we have a general surgery practice that actually has 2 locations across the street from each other because we didn't have enough space in one building. We have the same with pulmonary. Pulmonary's in one building. Their sleep services are in a different building just due to space limitations. So we've been able to build around those specialties to bring everyone together so that they are able to communicate and share patients. So we're excited about that. The other is that we've been able to really focus on efficiency. So a good example is that we will have one centralized check-in area in this building rather than having to go to various locations to get checked in and pay your copay. We also are implementing what we're calling digital front door. And digital front door is a link that patients can use to register themselves from home, and they can provide information to the practice. They can pay their copay, and that doesn't sound that efficient probably to most patients who think, well, I just go to the desk and somebody does it for me. But the great thing about it is that then you know your information is in there right. And you know that your bill, as a result, is going to be correct. It also means that when you get here, you say, I'm here, and you keep on going to your physician office. And we see that as a big benefit. We also will be able to expand those capabilities over time. We will be fully set up with the what we call our AI scribes, that ability to just talk to the physician or the nurse practitioner or PA in the exam room and have the AI create the note in response.
Have you seen any problems with AI as far as scribing is concerned?
We always expect the provider, so the physician or the nurse practitioner or PA to review their notes before they are approved. I have heard that sometimes before the AI gets trained by the provider that it might mistake certain conversations and assume that it is part of the clinical note. But we have that with anything, so it learns quickly, and the first time we identified that problem, we were able to resolve it.
One of the issues I've heard from some patients is the lag time in seeing a specialist, being able to get that appointment, sometimes weeks, even months, and concerned about their own health in that time. Is that something that you are looking into and addressing?
It is. So we're working on a few things. One is that we are streamlining our what we call our scheduling templates. So in other words, we've had a history of maybe scheduling provider visits at the convenience of the practice rather than at the convenience of the patient. And you and I are great examples of that. We don't have time to go to the doctor or the provider in the middle of the day. We just don't. We have other things that we have to do. So looking at earlier morning appointments potentially over lunch, later afternoon appointments, trying to make those available so that people can get in. And even if it's not for you, it could be for a parent or a child, you still need some of that flexibility on your behalf rather than just on the practice's behalf. So we have that. We are also working on a centralized call center. So rather than calling your primary care office and having them say, oh, we don't have any spots today, you should try calling urgent care, you would call one number and we would give you an appointment in the most appropriate location.
Okay, and doing that with the specialists as well then?
Yes,
okay.
yes.
Yeah.
We're actually going to start with the specialists. So all of the specialists in this building, they'll be our first foray into this centralized call center, and they will still have their, what I like to call their pods of expertise. So it isn't 20 people scheduling for everything. It will still be dedicated people for general surgery, for neurology, for neurosurgery. But the idea is by taking them out of the day-to-day practice operations, that will make them more focused and more efficient so that they can answer calls faster and solve problems faster.
What do you think is the greatest obstacle that's facing healthcare in our area right now?
Probably, I think the Big Beautiful Bill has led us to really looking at the services that we're providing and what we can provide in the future. And when I say that, what we're saying is, wow, we're used to making up for this service with this service, with financially. And that is going to impact our revenue and our reimbursement. And so really thinking about what are the best services we can provide to the largest number of people so that we continue to have access in our community.
So do you think that's going to be fewer specialists? People will have to go to Charlottesville, or what does that mean?
I think it is doing a better job of sending patients to the right specialists. So I think that we have a tendency to just say, well, I feel pretty good about the diagnosis that you got, but why don't we send you to cardiology just to do a check? And now we're really going to be focused on, is that an appropriate referral? And is the cardiologist going to contribute from a value perspective by seeing the patient so that we can make sure the most urgent patients get to that cardiologist first?
Now, as we look into the future, are you looking to consultants to look at where you need to be? We need this many cardiologists or this many neurosurgeons to keep up with the population and the demand we're going to need 5, 10, 15 years from now.
So when we think about demand versus the recruitment targets, we do have some insight from consultants, but it's really driven by that every 3-year community assessment. So we're trying to make sure that as we recruit, that we are lining up our recruits with the actual needs of the community. And there's some things that are easy to recruit. A great example is we're going to bring in 10 cardiology providers. And that was a 3 to 5 year target. We've already recruited all of them.
Oh, wow, okay.
That's exciting. But then we have other areas where recruitment has been slower. Primary care is a good example. And there isn't anywhere that I go that somebody doesn't ask if I can help them get into a primary care practice.
Okay. I think the bottom line is you understand, you're hearing people, you're trying to find the doctors.
Yes.
You're trying to find the care that the community deserves.
That is correct. It is correct. And it's a balance. That's the other thing. Because the number of providers out there is getting smaller, the expense of recruiting them, the expense of maintaining them is getting larger. And so we have to really think about what can we support and as a community, and then is this the right investment for us? And that data really helps us make good choices, I believe.
Okay. Do you have a message to the community?
The message would be that we would not be so concerned about the provider shortage if we could keep our providers here once they get here. And we are within about a half a point of the national averages when it comes to turnover for physicians and for nurse practitioners and PAs. So we're close. It's not like we're worse than someone else. But integrating them into the community is so critical. And the more help we could get from the community, the better I think we'll be able to retain those providers.
So when you say it's within the average, it's what does that look like?
So a good example is that I think the national average for physician turnover is about 10.3%, and we're at 10.8%.
Okay.
I have done this for a long time. In the old days, if we could get you and we were your first job, you would stay forever. It doesn't happen that way anymore. And so we are doing a lot of things to try to retain providers. We're looking at how their work days are scheduled. We're looking at ways that we can give them more balance in their lives, less paperwork, more staffing support. Anything we can do to help them feel like if their cup is empty after a day of seeing patients, they have the time to refill it before they come back the following day.
What do you attribute to that turnover rate? Is it going to another hospitals? Is it getting out? What's the turnover?
We're not seeing getting out unless there are retirements,
right.
But it is really more about that competition. If I have the newest robot in my surgery area, and there is a provider out there who really wants a robot as part of their practice, I'm going to go out and see if I can convince them to come to Lynchburg. And we see that from our competitors too. Here's the newest technology, here's the best staffing, anything that we can do to make it an attractive jump for those providers.
I think just like everybody else in hiring these days, quality of life
Yes.
is as important to the doctors and nurse practitioners and PAs out there as it is to anyone else who's looking for a job as far as recruiting is concerned.
That is correct, and I think healthcare came late to that. I think we just expected them to continue working the way that they always did, and we're having to pivot and provide this support and the connection. That's another thing that I would have never thought 10 years ago I would be talking to you about. But because we have a lot of providers who do not go to the hospital anymore, they don't necessarily meet anyone outside of their practice that they're practicing in. So we are consciously providing opportunities for them to connect with other providers, connect with the community, get out and do things that they're interested in an attempt to create stickiness with the community.
Okay, I think that's it.
Thank you for watching. Be sure to subscribe to our YouTube channel and watch more videos from ABC 13 News.